Welcome back to another episode of Outcomes by Design. I'm your host, Dr. Kristin Baier, Chief Medical Officer at Ansera. Today, I have a very special guest, Chronis Manolis, who is the former Chief Pharmacy Officer at UPMC. Chronis, hello. Thank you for joining us today.
Good morning, Kristin. Thanks for the opportunity. Happy to be here.
Thank you. And Chronis, why don't you give our audience a little bit of a background about your pharmacy experience?
Yeah, pharmacist by education. Started my career here in Pittsburgh at a local pharmacy in a poor community, and really learned a ton about the intersection between the provider, the patient, and the pharmacist. Really enjoyed my time there. Moved on in my career. I worked in specialty pharmacy as specialty was just starting. I also worked for a large PBM, but the last 19 years I ran the pharmacy department at UPMC Health Plan as the chief pharmacy officer, and just really really enjoyed my time leading a team that we felt like we made a difference.
That is great. And I am sure you came across the very popular GLP-1 medications during your time as Chief Pharmacy Officer. And it seems like with rising healthcare costs and increasing demand for high-impact drugs, such as GLPs, there's this tension growing between access and affordability. I'd love to get your thoughts on if we are entering a new era of drug access challenges.
Yeah, I talk about this all the time, Kristen. I mean, pharmacy is having its day in the sun. I studied earnings reports. I would listen to, I would read annual reports, et cetera. And, pharmacy was barely mentioned 10, 12 years ago. And now it is, out in the open from a CEO and a CFO perspective. And not only out in the open, but really the chief complaint of why premiums are rising or profits are going down or et cetera. And then, unfortunately, GLPs are the next thing that comes out of people's mouth because they're so recognized, and they're so in the news these days. And so, GLPs have been kind of unfairly thrown under the bus along with this complexity in this moment that we're having. And it's really, for me, um, it's the most complex we've ever seen it. Whether it's drug pricing, government regulation, PBM reform, the pipeline, and wow, the pipeline. Um, we are at an inflection point where we have such improvements in biologic innovation. We have we have government regulation, things like accelerated approval and voucher programs that are going to bring drugs to the market faster. And then you layer on generative AI, and that'll be the accelerant that really brings drugs to market. So when you think about it, how do we create that? The demand will be off the charts. There'll be life-saving therapies. I mean, cell and gene therapy is just starting to boil over. These are lifetime cures at seven-figure price tags. And, I think that that's the challenge that we have. So we have to keep focused on access and affordability, but it's hard to when you have all this noise coming. And I think that's the big opportunity and challenge right now.
I'd say one thing that really frustrates patients and physicians alike is the prior authorization process. And this is becoming a growing barrier, especially for diabetes and obesity drugs. But I understand their utility. I mean, we do have to regulate who gets these medications and make sure, the right candidate with the right indications is approved while, rightfully restricting access to medications when they're not truly clinically indicated. I know we're all hoping with AI, the prior authorization process does speed up and does not become such a time burden. But I understand that high cost drugs do need some type of regulation. How do we make these drugs more affordable, but not make them such a, process for people to access?
Yeah, it's quite the dichotomy because, you know, at the at the at the root of it all is a system we have in pharmacy that's really all about volume instead of value. And, early in my days at the health plan, we were starting the medical home. It was the beginning of value-based reimbursement rather than widget-based reimbursement. And you fast forward today, it's the standard of care. We're trying to do it in oncology and in kidney disease and lots of things like that. Well, pharmacy has to catch up. And you've got a lot of stakeholders in pharmacy that make it really hard to catch up, right? We didn't get here overnight. But the one thing we can do is the one thing we must do, and our stakeholders depend on us, is make sure that we have appropriate use and evidence-based use. And unfortunately, the tool that's most often used is prior authorization, and it's misunderstood. And there's no question that offices are inundated with these requests. And so it's on us. I spent a lot of years trying to say, how do we make this as simple as possible, as efficient as possible? How do we use AI? How do we use all this data we have in the EMR, that we have claims data? How do we pull it all up and make sure that it should be auto authorization. We only want to see the exceptions. And I think we've made a lot of progress there, but we still need to do more. But I think if you'd have told me, 20 years ago that we would be prior authorizing diabetes drugs, I said, no way. We're going to bring its system to its knees. And actually, we're going to put barriers in place to patient care that we know are going to cause unintended downstream healthcare use, et cetera. But that all said, I don't think we've had a drug category in a long time where it has this size of a population and the holy grail. How do you just take something and lose weight? And so, I always say, I did a lot of education over the last 5 years at my plan. That how did you let it get to this point? Well, wait a minute, like these are GLPs are great drugs for diabetes that we would want diabetics to be on. We don't want them on the old drugs where you can risk, hypoglycemic episodes and you name it, and they're cardioprotective and they're kidney protective and you name it, right? But something clicked after COVID and the explosion happened that these are also weight loss drugs. So we had to do something. So we had to make it easy and we had to do something. That's just for diabetes drugs. The, you know, Talking about coverage for weight loss is a whole different sort of philosophical issue that we've got to get to. And I think a lot of those discussions are happening inside of plan sponsors and plans.
Yeah, I agree. And, the price has been trending down recently. And I suspect in the next couple years, the price will continue to decrease. Similar to what we saw with statins, back when they first came to market. Now they're generics and they've become the standard of care. It is my hope and expectation that GLPs will follow suit because treating obesity is really like attacking, the disease process at the trunk of the tree and not individually treating the branches, which are the downstream effects of obesity, your type 2 diabetes and heart disease, even, 13 different obesity related cancers. So to combat, rising healthcare cost, it really is beneficial for the system to find effective therapies and allow for treatment of obesity. But when combined with the whole lifestyle behavior change aspects as well, it's not going to benefit anyone if we're paying for GLPs only to have high discontinuation rates and, really poor long-term adherence. And it's really just a waste for
Yeah.
those medications. So just making sure the medications are paired with the proper support, I really think is in the best interest of everyone and to contain healthcare cost down the road. Um, and with that, we're also starting to see more and more use of D2C pharmacies. I'll just say, like, taking out the middlemen and insurance and PBMs. And that is a way that a lot of patients are accessing GLPs now through like NovoCare or Lilly Direct. How do you see that? I'll say transpiring into the future. Do you think D2C pharmacies are going to play a more prominent role, or do you think they're going to hit their breaking point and we're going to have to go back to figuring out how to make these affordable within the traditional healthcare system?
So, boy, you asked a really interesting question there, right? I mean, when I look at all of the products in the pipeline, I call it the GLP gold rush. You say to yourself, it's amazing. Like, do we really need drugs that are better, right? I mean, we're losing 20 to 25% of our body weight. And we know a lot about these drugs. They've been road tested for a number of years. So I think so. So let me try to unpack that question. I think overall D2C is great. If you look at lifestyle drugs that have over time erectile dysfunction, it's pretty much all on the secondary market. Once they went generic, it's pretty much all direct to consumer. I think weight loss drugs really lend themselves to that, but how do you get the support if that's the direction you go? So we're in this transition period. If you ask me that question 5 years from now and we have multiple generics, then maybe, yeah, the answer is, you go there and you try to package it with some kind of education program. But along the transition, if employers and plan sponsors and health plans are going to pay for this, they're going to want the combination, right? They're going to want to make sure that their investment in this drug is really protected through a holistic program. I think there's lots of drug categories that actually require, companion education and support. Otherwise, people will just, this is what drives me crazy. The big excuse is that, well, patients will go off drug and they'll gain the weight back. There's lots of drugs that we pay for that people discontinue taking them, you know, bad things happen, right? So let's not single out this one and call it lifestyle, because we've spent years creating benefit designs, because obesity it's got such profound downstream effects. We finally have drugs that work. How do we, and again, I go back to categories like hepatitis C, where we just true innovation. And I would put this in the true innovation category, but just an imbalance to the amount of funds to afford it. And so we started with the highest risk patients. And then you fast forward, and these drugs, we don't even authorize anymore. So I see GLPs as going through this sort of temporary, transitory, probationary period that is driven by our environment and these broader cost pressures. But I think as more D2C weeds out the casual users, we see a price drop, and I think Wegovy with the MFP may be that potential. We will start to get more evidence about the cost offsets. We'll get more indications that these drugs should be in the water, right? That they're that good. And I think you'll start to get acceptance. Um, but I think at this point, given that demand is so is so big, that people are going to want to crawl before they walk.
You're absolutely right. I completely agree. And GLPs have actually been available since 2005. 2005, with Saxenda being the first weight loss approved GLP coming to the market in 2015. And it's like they just exploded. But they still are in their early phases, I will say, of acceptance.
Mhm.
And we are seeing more and more indications and lots of trials going on for even more indications beyond type 2 diabetes and beyond weight loss. So I think these drugs are absolutely here to stay, and they're going to have more indications coming very soon. But I think you hit on something very important, that it really does need to be wrapped around with education. For patients that have type 2 diabetes and it's a new diagnosis, they're all getting referrals to see a dietitian as well and get pretty extensive education
Mhm.
on the disease. And I think obesity has to be treated the same way there. And I think it really does take, a broader system. It's not just, the pharmacy's responsibility for improving access and affordability, but it really is a healthcare issue where everyone needs to contribute to the solution here to control healthcare
Yeah.
cost. Um, and with even more effective medications in the pipeline, like retatrutide, it'll be interesting to see what happens to kind of these original weight loss GLPs that might become first line, where some of the more effective ones are second line, or we see higher BMI indications. It's also going to be interesting to see how they're classified. If I believe it's Eli Lilly is trying to get retatrutide approved as a biologic to help prevent some of the compounding that's been going on that we see with semaglutide and
Yeah.
tirzepatide, where you can buy them at a med spa. And as a physician, that makes me really nervous. And I
Yeah.
think that's when you start seeing people end up in the ER with side effects. They're not getting personalized care. They're not getting that wraparound support. And that's concerning. And we definitely understand the excitement around the medications, but they do need to be used appropriately and when clinically indicated. So moving forward, what needs to change? What gives you optimism about this field and about GLP medications and expanding access to care?
Well, again, like I said, I think these they're remarkable innovation. We have lots of years of data, so it's not like we're kind of, as you mentioned, it's 2005. Um, I just think that all this pressure, and really the biggest pressure is the fact that obesity drives so much downstream, issues and cost and admissions and poor quality of life, that really, how do you ignore innovation? You can't. And so my hope is, we get, so first and foremost, I think that all the key stakeholders have to lean in and get uncomfortable, right? So, manufacturers, they don't want any utilization management. They want these drugs to be out there. And, payers, we want we want to pay for drugs that the way they were studied in the populations that they were studied. I don't think that's a big ask. But those two things, I think I think stakeholders have done a good job. Manufacturers have allowed criteria. Um, Payers have managed the criteria, but payers also have to recognize that, hey, um, I'm holding on to my members longer. I'm gonna get the downstream benefits. Employers obviously look at productivity, engagement, absenteeism of their employees. Of course they wanna cover these. They look at the health of their the health of their portfolio of employees and say, why am I holding back on this? And so I think what you'll start to see is, as the price drops, as the data comes forward, as D2C takes things away, I think you'll start to see adoption. And that's what gives me optimism, because a lot of people actually can't access these drugs. They're too expensive. They are resorting to compounding. They're resorting to other factors that What I worry most about, very similar to you, Kristen, is we're creating fragmentation in care. Those claims are not in the purview of the clinicians who treat these patients. So any med reconciliation, or you walk into a pharmacy and you get a claim filled, that GLP is not in your profile to look for drug interactions. So we're going to have to solve both of these. How do you keep it in the pharmacy benefit? So everybody who has access to your care can see it, but how do we make it affordable for everybody? And I think some of the work on Medicare, as Medicare tries to put this out there, is going to just create even more pressure, right? So the states were covering obesity, they kind of backed off. That's more of a budget thing, but you'll start to see more of these demonstration programs. If Medicaid and Medicare start covering these drugs, it's going to create a lot of pressure on the commercial plans. And so I think there's already cracks in the sort of the foundation, and you're going to start to see adoption. The drugs are simply too good, and the benefit is too good to. We just need to make sure it's for the appropriate user. And if it's not for the appropriate user, there's probably other avenues to access the drug.
Right. And the noise has become too loud for
Yes.
employers to ignore as well. And they're terrified of the cost and,
Yeah.
helping them find feasible solutions where you can use the drugs in a responsible manner is really the answer right now until the price does decrease, and making sure it has that accompanying wraparound education to go with the medication to ensure the best outcomes and a return on your investment for employers. But I'm really excited to see what happens with Medicare and Medicaid and the pricing and greater adoption of these life-changing
Yeah.
medications. So, I want to ask you one last question as we wrap up here today, Chronis. And again, thank you so much for coming on. But what does better look like for patients and for providers and employers?
You know, I mean, I think the ultimate prize is that these drugs are accessible without authorizations. I think what I really don't want to do is actually penalize the diabetic because of the people that want it for weight loss. And, that it's a really complex issue. Um, but I think, again, as the environment improves, as the category becomes less costly, and I think it's going to get there. We may even have generics in the near future, and then people can decide whether you want the 1.0 version or the 2.0 version.
Right.
But there's nothing wrong with the 1.0 version. I mean, we talked about this, right? Blood pressure statins, SSRIs, PPIs. I mean, drugs that came out 20 years ago are still the standard of care. They're still effective. They're cheap. We give them away. Do you dare think about an environment where, you know, we get some generics that come to market and they're just open access. And so I don't think that's very far fetched, but a few things have to happen before that gets there, because I think we can really change the face of obesity. And when you think about how we can get our population healthy, this is a remarkable tool that has downstream impacts on cardiovascular, kidney, and arthritis and sleep apnea, and you name it. So I think they're too good to be held down. We just need to sort of crawl through this environment to get there.
I completely agree. And we're seeing GLPs. I view them as a tool to increase health span, not just lifespan, but the quality of life and having healthy, good years, reducing your risk of cardiometabolic disease, resolving sleep apnea, preventing diabetes. That's what it's all about, right?
Right.
We're not just trying to help people lose weight for cosmetic purposes. There really
Yeah.
is a
Right.
bigger issue at scale here, and it really comes down to increasing health span. So again, I'd like to thank you for coming on Outcomes by Design, Cronus. It was an absolute pleasure to speak with you today. I learned a lot, and I'm sure our audience did too. So So please come back again. We'd love to have you on anytime. And we will have another episode of Outcomes by Design coming soon. Thank you, everyone.
Thanks, Kristin. Appreciate it. Thanks again for the opportunity.
Our pleasure.
Take care.